Good afternoon, everyone, and thank you so much for joining us. We'll just wait another minute to let everyone into the session. For those of you who are just joining us, this is a telehealth immersion program session focused on implementing innovative solutions with an equity lens. And before introducing our speaker for today, just a couple of quick housekeeping notes. We will be reserving time at the end of today's session for Q&A. There's a Q&A function down at the bottom of your screen. Feel free to type any questions that you have for Dr. Lyle today, and we'll be sure to reserve time at the end to answer those. And this session will be recorded and made available on our website after today's event. All right, and it is my privilege to introduce today's speaker, Dr. Courtney Lyle. Dr. Courtney Lyle is an associate professor at UCSF in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital, the Center for Vulnerable Populations, in the Department of Epidemiology and Biostatistics. A trained health services researcher, she uses quantitative and qualitative methods to design, evaluate, and disseminate digital health solutions that work for all patients, particularly the most underserved. She currently serves on the AAMC Telehealth Advisory Committee, the Patient Portal Engagement Committee at the San Francisco Health Network, the San Francisco Digital Equity Initiative Advisory Board, and the board of the San Francisco Public Health Foundation. It is my privilege to introduce Dr. Lyle. Dr. Lyle, thank you so much for joining us, and I will turn it over to you.
Great, thank you so much, Bernadette and everyone at the AMA for having me today. I'm excited to talk to you about implementing telehealth with an equity lens. So just a few disclosures from some projects that I work on, but I'm not going to be discussing any of these places or tools today. So to get us started, I thought I would just sort of lay out an objective that we work on in my lab and with my collaborators at UCSF is really just digital health equity and the idea of implementing new healthcare technologies in an equitable, inclusive way to really impact both historically and presently marginalized communities and the clinicians and systems that care for them. I'm going to be emphasizing telehealth, given the rapid expansion of telehealth in the past year, but I think a lot of what I'm going to talk about today actually is relevant outside of telehealth as well. So in terms of an agenda, I thought I would just sort of set the stage with a lot of details and facts about where we're at both the patient level in terms of telehealth, as well as the clinician and system level. Focus on the major opportunity areas that I think exist for us to move forward and to make bigger impact in this space. And then there's a number of resources and practical tools and strategies that I hope to leave you with in the second half of this talk. Okay, so to get us started, I would say this is sort of the high level of lots of things that I'm going to talk about today. And I think the main lesson, there's a lot of text on the slide, but the main lesson that I want to leave you all with is really how multifactorial digital health equity really is. I would say sometimes it's a little easy for people to focus just on the patient level barriers to technology adoption. While they're very important, I think there are many, many factors at play in terms of how we choose technology, implement technology that impact the disparities in uptake and use. And so I'm going to spend a lot of time showing data in the orange circle at the patient level and also talk specifically about systems in the sort of green layer here, but I don't want to, I frankly want to acknowledge up front that there are actually other layers at play as well. So at the community level, there's of course trust in our healthcare systems, disinvestment, systemic racism that underlay all of the types of things that we're trying to do with digital health and need to be thought of in really structural and systematic ways if we're going to make progress as institutions to reduce disparities overall, regardless of digital health or telehealth. And then at the industry and policy levels, while I'll talk about them a little bit, I would say we have a lot of work to do to make sure that the platforms that private sector are offering and are equitable, they're usable, that they really have an emphasis on equity upfront. in addition to some of the things that I'm sure you all are working on, which is really trying to make sure we're reimbursing and paying for both healthcare specific tools and strategies like new telehealth reimbursement models into the future, and even things outside of healthcare like broadband expansion that will really, really affect all layers of this model here. This is sort of a Cliff's Notes of things that I think are happening in today's world, and I'm going to dig into some of these barriers in a little bit more depth in this talk. So when we think about telehealth, I would say, I wanted to give some data on where we were before the pandemic. It's almost like, how can we think about where we were before the pandemic? It feels like we've been here for a long time, but there's a lot of things that were happening within the ecosystem for digital health prior to COVID that actually, I think, affect rather where we are today. So these are data pre-COVID from a digital health incubator called Rock Health. And it's a national survey that they conducted in 2017. And what I like about it is it's just sort of a national survey about what types of digital health products different consumers were using in 2017, sort of a snapshot. But what I think is really interesting about these data and sort of historical lens is that they asked about telemedicine and specifically video visit implementation and uptake among different groups. That's the top row that's circled in red. And then they oversampled within this survey 4 segments of the US population. So chronically ill seniors, a group that they called vulnerable, worried well, and aging adults. And the category that they entitled vulnerable is really sort of, I would say, an emphasis of this talk today, which is lower income individuals and those covered by Medicaid. And I think what is really interesting to look about 5 years ago or so is to see that, of course, there were huge disparities and gaps in who was using telemedicine across these subgroups, with some of the groups like vulnerable individuals and those chronically ill seniors being the least likely to have tried out or be using telemedicine and video visits in an everyday basis. And I think that a lot of that sort of carried forward into today. And so we can talk about some of what the stats look like today and what the barriers and facilitators were for this sort of environment. But the last thing that I think is really interesting about these data is the 4th row, that the interest is really high among all these groups. So when you look at something a lot more generic outside of telemedicine use or wearables or tracking, almost all the groups had a majority, frankly, all of the groups had a majority of individuals who were searching for online health information. So I say this speaks to both, yes, there were disparities pre-COVID and how we were thinking about telehealth, but this really high interest for using online services among all subgroups, all types of populations in the United States prior to COVID. And I would say we haven't matched that potential and that interest in what we've been doing today. And so sort of that disconnect is what it drives me and my team's work to think about and to dive into these topics. So that's pre-COVID. The next data I wanted to show was sort of, during the pandemic, what has telehealth really looked like as we've rolled out rapid scale telemedicine to pretty much a majority of Americans over the last year and a half or so. And with a specific focus on safety net healthcare delivery systems, where I'm based in my primary appointment at San Francisco General and in other community health centers, federally qualified health centers, and public hospitals, I would say the picture looks a lot like this. So at the top bar shows blue, the denominator of all visits, and in orange shows in-person visits. And you can see a huge decrease in in-person visits as the pandemic expanded in the United States around March and April of last year. But what I think is really, really telling about this graph is this dark gray bar about phone visits versus video visits that were happening in safety net sites. So almost exclusively phone visits as telehealth modality and across these 40 safety net systems in California throughout the pandemic. And this only went through August of 2020. They've refreshed these data. I've seen some of them. I think these patterns have continued. At San Francisco General, where I am based, and at many other safety net sites, telemedicine has looked like audio visits, telephone visits over the past year. And a slight increase in video, but a very small increase in video. And when I to think about that, there, like I said, as I sort of outlined this talk, there are just many, many factors that go into play here. And so just to try to tease that apart. So that's where we were before COVID. And then that's sort of what's happened during COVID, well, specifically in safety net delivery systems. But sort of what's underlying that and how can we really make impact without, we have to sort of tease apart and understand the layers underneath that. So at the patient level, I would say we also have sort of three major pillars or stools, legs on the stool, sort of how I think about it, that impact where we are with patient-facing barriers to telehealth. So at the one level, sorry that these aren't loading. Oh, there we go. It's taking a lot of click through. At the one level, I would say we've heard a lot about video-enabled devices over the pandemic. So do patients have a device that has video and that can handle a video visit for telehealth in the time of the pandemic? And what does device ownership look like in the United States? At the second layer, I think we've also heard a lot about high quality data access. So do people have broadband at home? Do they have a data plan on their cell phone that actually can support telemedicine use and things like that? Thank you. Somehow it's not advancing for me very fast. And then the third leg of the stool is really about digital literacy, which is really about, I would say, the skills and the tools to be able to use their device and to use their internet and data plan to be able to take up what we're offering in real time. So to sort of again, give you some national data on what that looks like, I would say this is a slide about the digital divide, sort of who's using the internet from the Pew Research group in 2019, so right prior to COVID. And these data, I would say, were not necessarily super well known pre-pandemic, but I think that everyone is a little bit more, has been really realizing over the last year and a half that there is a pretty sizable proportion of the United States population who is not online. So this looks like the difference between the lowest income groups and some of the higher income groups in this national data, almost a 20% difference in who is using the internet pre-COVID. And this is showing you by income. There's similar patterns that look very similar to these trends by age, with older adults lagging behind, and by community status. And so rural communities sort of being left behind. The other area that's really interesting here is thinking what I call sort of the digital divide 2.0. So not just about who's online, but really about how people are accessing the devices and tools online. So even when you think about people who are smartphone users in the United States, this graph shows sort of the opposite trend than the one I showed before, with the lower income groups in the United States being significantly more likely to be using their smartphone only for internet access. So this means that more than a quarter of the lower income groups on this national data from Pew were only using a smartphone and only using the cellular data on that smartphone to access the internet. They may be using public Wi-Fi and other things as they go about their life, but in terms of at their home, they do not have a wired or Wi-Fi broadband connection. And I think what's interesting about this is it's sort of a very nuanced way of thinking about how people use the technology in their everyday life. And if you think about something very specific like video visits with your doctor, if you have a smartphone and you have a limited cellular plan, whether or not it is capped at a certain amount of data per month, or whether or not it slows down your speed at the end of the month, it looks like it's a very different situation in terms of whether or not you want to have a video visit with your doctor than individuals who have broadband and have other ways of accessing things at home. So it creates a very different infrastructure for what you might be doing. And then on the third leg of that stool, sort of the digital literacy and skills component, there unfortunately isn't really great national data on digital literacy, but we do have data in San Francisco as an exemplar. And I think San Francisco is a really interesting use case, given that we're an urban environment and we're a relatively tech-connected city, given our proximity to Silicon Valley. Within our city, we're really blessed to have something called the Digital Equity Initiative that sits within our mayor's office of housing and community development, who was able to conduct their own survey locally of San Franciscans to try to ask specifically about internet use, yes, but also about these basic digital literacy skills. And what I think is really important in this graph to focus on is that people who are both internet users and who self-report having basic digital literacy skills, like being able to find a website on their own and send an email on their own, is pretty high overall among the San Francisco population at 85%. But when they were able to break out their survey data by some of the subgroups of populations who were more likely to see at San Francisco General Hospital as the public hospital for our city and county, you see that this purple bar tends to expand in terms of people who might be using the internet, but actually self-report having barriers in doing basic things online. And so what this means is that the proportion of individuals who actually might have challenges related to digital literacy is actually larger than it might seem at first pass. So devices are an issue, and the right types of data and broadband are an issue, but also the skills are really critical. And when you put all three of those together and you break it out by important subgroups of our patient population, like older adults or low-income individuals and those kinds of topics, it actually is a relatively large proportion of these populations who are facing either a structural barrier for not having broadband, or financial barrier on owning a device, or need more support and technical support in using some of the technology that we're offering them. So I want to leave you with this idea that it's a larger proportion than maybe it seems if you took each one of those pillars and legs of the stool on its own. Okay, so that's, I would say, some of the best national data that I can give you about sort of where we were pre-COVID and sort of what it's looking like post-COVID related to the digital divide in the United States. Of course, there's also there's many other concentric circles and sort of where I started out this talk. So thinking more specifically at the clinician and system barrier and what we've been doing to think about telehealth at lab level, I thought I would show a little bit more in that domain as well. So sort of to parallel the types of topics that I showed at the patient level, I would say there are also multiple things at play at the clinician and system level. While many healthcare systems have been able to scale a lot of telemedicine during the pandemic, I would say video-enabled devices continues to be a challenge for some healthcare delivery systems, including my own delivery system, who were not on did not have a large-scale implementation of telehealth prior to the pandemic, and therefore did not necessarily have video-enabled devices in the hands of every provider or every workstation to be able to put that into place immediately during the pandemic. So I'm not going to spend as much time talking about that, but I just wanted to underscore that that actually is a capacity and infrastructure issue for some healthcare systems in the United States. At the platform level, of course, we have security and privacy concerns, especially as we move out of the emergency phase of the pandemic to consider. But we also have the platforms that need to work within our delivery systems, whether or not they're integrated into our electronic health record, whether or not they are easy to use for both clinicians and for patients, and things like that. So the platforms themselves can become important drivers of uptake and use at the clinician and system level. And then on the third piece, of course, I think a lot of us have been thinking a lot about workflows and team roles and things like that that will actually be changing to be able to do telehealth at scale. So those are, thinking through the multifacets of this level of how we need to be organized in order to make impact on this space. So to sort of wrap up the data of what I have to offer you, there's been less studies during the pandemic of sort of what have been the drivers and facilitators at the site level in terms of telehealth. But I will say there are some data pre-COVID, again, sort of parallel some of that Rock Health data that I showed you above at the patient level, the consumer level. When we're focused on delivery systems like community health centers and safety net sites pre-pandemic, there's been some data published, and it's using 2016 data that show that actually only about between 10 to 15% of sites, the community health center sites nationally, were implementing telehealth at community health centers. And frankly, there was only another 15 to 20% who were even exploring it. So when I was talking about sort of the rate of telephone visits and the rate of video visits happening in safety net healthcare systems during the pandemic, I think this gives a good snapshot about where they were right prior to the pandemic in terms of their readiness and and where they were on the trajectory and spectrum to launching telemedicine in the last year and a half. And then the second part of this paper was asking them the reasons why they had relatively low adoption of telehealth pre-COVID. And I think that the part that I wanted to underscore here was, of course, reimbursement for telehealth continues to be something that we all are worried and concerned about, keeping sustainable models of reimbursement. But technical issues at the sites themselves were really prominent barriers for these community health centers. So the same way in which I showed that digital literacy can be barriers for patients, I would say we cannot overlook the technical barriers that might be at place at the system level in order for sites to deliver telemedicine at scale. And so, it's really interesting to see that pre-pandemic and then to think through where we've been at during the pandemic. And then lastly, I thought I would just sort of mention, of course, that there's other data outside of telehealth. I've been very telehealth focused because I think all of you are really telehealth deep in sort of what you've been working on in the past year and a half. But we also have studied a lot of other implementation of innovations in safety net healthcare delivery systems and in systems that serve a disproportionate burden of underserved or marginalized populations in the United States. And I would say, to boil it down to a couple of bullets, it's been really clear that we need to design our implementation of new innovations for these systems and these patient populations from the outset. That when you're designing something for different systems, it's not as easy to adapt to different populations and sites than potentially how it seems from the outset. And so trying to co-design and think about implementation workflows specific to these sites, I think is really critical to equity. Sites also who have a higher rates of understaffing and staff turnover tend to need different types of technical support and assistance to launch new programs like telehealth at scale. And I would say it really shows sort of the huge amount of work that actually went into the pandemic, even though the video visit rates have been low at safety net healthcare systems over the last year and a half, I would say. The amount of work that goes into trying to recreate the staffing structures and the workflows at all sites really just can't be overlooked in what we're going to do moving forward. I guess the bottom line here is what I'm trying to say is it's not as simple as turning something on and offering it to everybody. That implementation issues like staffing models and finances really are core to what we're trying to do and actually affect equity at a very fundamental level. Okay, so hopefully that's not too doom and gloom, but I would say trying to show you the best data that we have available to us. What about opportunities, right? So that's sort of where we are. We have a lot of work to do. What opportunities do we have to make changes and to implement new programs and products? I would say I wanted to show this example or this definition rather of health equity to sort of make the parallel between technology and what we can get with health equity. So you might all have been seeing this before from the Robert Wood Johnson Foundation or other places who have been putting out visuals and definitions of equity, including AMA's definition and work in this space. But essentially, if you're thinking about this bottom panel of equity being able to really deliver tailored support to individuals as they need it, technology to me is a really opportunity space. Right? Technology does have the ability to tailor things based on individuals' digital skills, based on people's language, the reading level, all those kinds of things. When I present barriers, I think we need to be thinking about technology scaled and personalized to individuals in this kind of way to actually make impact and equity. Another opportunity space that I alluded to on the Rock Health data, but is true about telemedicine during the pandemic as well, is that there's a really, really high interest among patients in using modalities like telemedicine video visits and other digital health interventions. This is one example of a paper that we put out this year that showed, it's a lot of data on here, but really just tried to offer video visits and then ask about barriers among as many patients as we could who had an upcoming appointment in our primary care clinics at San Francisco General. And you can see in the middle panel that 65% of the patients were interested in video over phone visits, and 54% practiced and were able to test out a video visit on that call. That's despite many barriers that were already covered in terms of data barriers, technology or confidence in technology barriers, and device barriers that I've mentioned previously on previous slides. So this interest is prevalent, but I would say we haven't fundamentally addressed some of the other barriers to meet the interest that we have. And so that's on the patient side. This, I would say, a high interest and a desire for tools that improve the convenience and quality of care that they're delivering. And then I would say at the clinician level, we've also been asking our clinicians sort of their interest in doing video visits post-pandemic. And this is just sort of two panels from a different paper showing that the likelihood of continuing with telephone visits and video visits post-pandemic is high, with some quotes to show that providers and clinicians really understand and recognize the convenience of telemedicine, especially for patients who face barriers with transportation or mobility, and or getting off of work for visits, and trying to understand how we can adapt our systems to meet these needs of patients and deliver the care at the right time in the right place. So the opportunity is, I would say, high. And then the last opportunity spaces, I think, come from what we've been doing in other domains. So we've been studying online patient portals and implementing online patient portals in our delivery systems for many years now, places like Kaiser Permanente, where we did a lot of this research, probably 20 years now, and in other sites, even at safety net sites, we've been implementing patient portals for ever since the HITECH Act for at least 4 or 5 years now, depending on how quickly they were able to purchase electronic health records. And I would say the opportunity spaces from this body of literature that I think we can bring forward into telemedicine have to do with really understanding patient preferences and meeting them where they're at. So really understanding how to blend in-person and digital modalities, and how patients have preferences, and frankly, trust with providers, trust in our delivery systems, and which modalities support their relationships and the types of communication that they want to have. So how can we bring that in into what we're doing with telehealth? The lack of perceived need, or sort of when these different modalities are relevant for different patients, has to be addressed, and being transparent with patients. Patients have told us in multiple studies about the need for more technical support to be able to use patient portals effectively, and that technical support is directly tied to their uptake and use. And so how can we take that finding and translate it into what we're doing with telehealth uptake? And then, of course, we cannot forget some of these groups that I've alluded to and mentioned a few times. Those who have communication barriers need to be front and center with how we implement new digital health modalities, like those who are preferring to speak a language other than English, and those types of populations, like not designing for the people that are only ready to use our digital health platforms or telehealth platforms right away, but designing specifically for those who might have barriers, because it makes everybody's experience actually easier and simpler to do. Okay. So that was sort of the first half, trying to give you as much data and as much citations if you're interested in sort of where we're at with telehealth, and specifically different studies that talked about barriers across both the patient and the clinician system level, to sort of the context for where we're at today. I thought I would end with sort of more action oriented. So that's sort of where we're at, and sort of some of the drivers that we know from research. But what about what can we be working on today to improve our equity and how we're implementing technology like telehealth? So we spent a lot of time working with a team that we collaborated with for a long time called the Center for Care Innovations on a telehealth telemedicine for health equity toolkit that is linked here at the bottom of the slide. And this was funded by the Commonwealth Fund, and we launched it, I believe, in October of 2020. And then we just did a refresh of content on this toolkit only a couple of months ago. So it has pretty recent resources, and hopefully all of you will be able to check it out. The way in which this toolkit is organized is really thinking across some of those levels that I showed in those concentric circles at the beginning of the talk. So not perfectly parallel, but sort of thinking from the basic level, the leadership considerations for vendors and infrastructure, privacy and security, then moving down into the clinician, provider, and team level to understand workflows, and even thinking through provider well-being and burnouts at the team level. Different resources for engaging diverse patients in terms of device access and skills and technical support, topics that have already come up a number of times in this presentation. And then what we called optimizing for the future, so more advanced telehealth workflows moving into the future. So there's a lot of resources in there. I thought I would just try to boil it down to some overarching strategies and then to sort of some specific use case examples centered around a visit. So at an overall strategy level, I just want to emphasize that we can't do well with improving equity with telehealth or any other digital health implementation without really knowing where the disparities lie. And so to know the data on disparities within our own healthcare delivery systems, it's incumbent upon us to both look at our EHR, to review data, to have really good, robust indicators about who's taking up different modalities, who's being offered different modalities, as best of data as you can possibly glean from the structured fields in the EHR, who's completing video visits, who's registered for the patient portal, who's using and logging into the patient portal. Those are kind of data that are available in our electronic health records and can be stratified by other variables that were already collected and self-reported by patients, such as their race, ethnicity, their language, and other fields. So we have to be thinking about our EHR data and using it. And then the other domain would be to understand where patients are at across their digital literacy and digital access spectrum. So potentially adding new questions to make sure that we're understanding patients' interest, their devices, their data, and their skills, so that we're offering the right type of digital modality based on their needs and preferences. And I'll touch on that in one more second in a little bit more depth. That's sort of an overall strategy. In order to make a dent, we have to really be tracking our data. And sometimes it might be existing data in the field, and then it also could include some new data that we might need to be asking to make sure we're offering the right resources to the right people at the right time. The second overall strategy that I really want to leave you with is really thinking about the number of community-based resources that are available to us in this digital inclusion and digital literacy and access space. So I would even suggest that these types of resources in terms of digital access and inclusion are potentially like a social determinant of health. So the same way in which we might screen for food or for housing among our patients, if we're willing and invested in screening for digital needs among our patient population, there's a similar suite of resources and referrals that we could make out into the community to identify tools and resources for people to get connected. So there are many of them. There's many things happening at public libraries. There's many things happening at local community-based organizations. Some of the ones that I wanted to highlight here was a group called the National Digital Inclusion Alliance, NDIA, which keeps a comprehensive list of free and low-cost internet, including things that have been expanded during the pandemic, and has local chapters throughout the United States that may be of interest to you all. And also a national program that you might be familiar with called the Lifeline program, which used to offer hard lines in people's homes, but now covers smartphones and also low-cost data plans for people who qualify, often for other types of public benefits. So in California, if you qualify for SNAP benefits or food stamps, you can qualify for the Lifeline program. And then there's other resources out in the community, like PCs for people that offer refurbished and low-cost devices. So there are actually a number of tools to get people connected. And then there's another sort of parallel set of resources that are about the skill building, like I mentioned, like at public libraries and others. And so really thinking about referrals and connections in the digital space that might parallel some of the other work we're doing for social needs of patients. So those are the sort of two high-arching strategies I want to leave you with. At a slightly more granular level, I thought I would walk through just one example workflow to sort of put some of that into practice, right? So this is not, by any means the end all be all workflow. I just thought it's a nice crystallization of trying to take some of those big strategies and then put it into practice. So When you're thinking about then offering something like a video visit to patients in everyday practice, how can you think about the team roles and responsibilities that might be at play to make sure that you're, again, offering the right thing to the right person at the right time? So in order to do the right kinds of screening and to really understand who's ready and interested for telehealth, there are some linked screeners here that might be helpful to assess people's device ownership, people's data access, and their skills and confidence in doing tasks on their own with their device. So even just calling up patients and when you're scheduling them for upcoming appointments, just trying to make sure, even with 3 questions, 4 questions, can you get a better sense of the interest and the readiness of patients to make sure that you're offering them the right thing? Like, is video the right thing for this patient today? And if it's not the right thing for them today, maybe that's when you can do some connections into some of those other community-based resources. If they don't have a device and they're interested in having a device or something like that, that's the right time and triage point to make sure that we're understanding what patients are interested in and then trying to offer the right things to them based on where they're at across that spectrum of digital needs and skills. And then, of course, to address that technical support issue that's come up quite a bit in patient portal research and some of the work that we've been doing, you need to make sure that these team roles and workflows then allow for the right time to connect and to practice the skills for patients who might need more time. So can we think about workflows that actually allow for more time to connect, or practicing connecting on video visits that have the right person assigned on the team to help patients with that, especially the first time that someone completes a video visit or the first few times that they complete a video visit, because that's the kind of thing that I think helps people feel supported and makes them want to come back again in the future. And then, of course, reminders, integration into other things we're offering in the EHR, the more seamless it can be and the more support people can have to do it, I would say the better. So that's sort of a granular example of how you think through what the patient's needs are and then prepare a visit that actually might meet them where they are. During the visit, I would emphasize from an equity standpoint, of course, this idea of really surrounding the patient during a video visit that parallels what we might do in an in-person visit. So seamless access to language interpretation comes up quite a bit in our delivery system to make sure that that is something that can be launched directly from the video visit, and that other family members, if the patient is interested and feels comfortable having others engaged, might be a really important thing to help with digital troubleshooting during the visit itself. So how can we extend and make sure that the video visit allows others to come in as needed and as wanted by the patients? And then lastly, post-visit, I would say some following up and closing the loop is particularly important for telehealth, especially, like I mentioned, for those who are trying it for the first or second times as they're getting used to it. So following up with the clear instructions and information, as well as maybe a team follow-up call to patients to make sure that they were able to connect the way that they wanted to and didn't have questions or concerns. So trying to wrap around visits to really meet the needs of patients, I think are effective strategies, even if it's just intensified on those who need the most support in trying out this new modality for the first times. I wanted to mention, again, the language access piece within the after visit summary. I think there are other tools that we can be integrating into our workflows. We've done some work with Google Translate up on the patient instructions section in the after visit summary. And so thinking through making the after visit summary and the instructions to patients as linguistically and literacy relevant as possible, so that they're leaving with the most concrete information from the visit, and also maybe even the same things about instructions for getting online, trying to use different tools in addition to live interpretation services. And then lastly, I think those first ones are really focused on the visit themselves, the medical content of what's happening and making sure you can close the loop and sort of make sure people were able to engage. But then I would say the same way that we assess patient experience with CAP surveys and others, I think there's a lot of good examples actually on the toolkit if you're interested in thinking about how do you assess patient experience specifically with telemedicine as well. So how can you send surveys or follow up with patients to really understand their experiences and continually improve on what you're offering? Okay, so that's sort of I would say the first part, the core of what's available in the toolkit, and hopefully a helpful example of what a workflow might look like. I don't have as much time to go into that optimizing for the future, that last section of the toolkit today, but I just wanted to mention that there are many, many tools highlighted on the toolkit, including the AMA Digital Health Implementation Playbook about remote patient monitoring, population health measures, and some of those other tools if you're interested in trying to think through some of the more advanced use cases. I think I've emphasized a lot today on the basics, the foundation of making sure people are ready and interested and able to use just a video visit at the outset. But I think a lot of the same principles in terms of technical support, human support, like call centers, calling back patients, offering of patients additional support measures, those kinds of things matter for these advanced platforms the same way they matter for getting people onto a video visit at the outset. Okay, so I just put a lot of information down. I thought I would try to summarize sort of what these recommendations might look like then. So I think there's a lot we can be doing. I would say even focusing on a few of these, I mean, this is a very sort of exhaustive list of recommendations, but even thinking through where are the priority areas for your institution or your practice and where you can be focusing, these are examples of things across the levels that I think can make some impact in this space. So at the patient level, I think we really need to be thinking about understanding the in-person relationships that patients have, both with their providers and teams, and also the institutions that we're practicing in, and trying to make sure that we're offering digital modalities as an extension and support for those in-person relationships rather than as a replacement for in-person care. So really trying to understand how we're fitting in digital into the rest of our delivery and not necessarily, and making sure that patients don't feel like we're trying to push them out or squeeze them out into digital modalities alone. And then really understanding what their individual perceptions and barriers are about the new services and platforms that we're offering. So those are two key strategies that we can do to ensure that we have at least better awareness and understanding of what we're trying to offer in our delivery systems. At the clinician system level, I think I gave you some examples of better ways and hopefully simple ways to screen for devices, high-speed data and internet and digital literacy skills. Really thinking about what the technical support that we're offering patients and families looks like and how to either bolster that or make their higher awareness of the existing technical support. Selecting vendors and platforms that can make things like interpreters and really seamless, easy to launch video visits more wide scale, so that we can get around those kinds of fundamental barriers that might leave out certain populations. And then, of course, I talk through team-based workflows that really support patients in practicing things and following up with patients. And I didn't have as much time to go into it, but we also clearly need to be thinking about workflows that also support clinician and team burnout. And then lastly, at the policy level, I hope I've given you some examples of how the healthcare system can really be connected better into the existing infrastructure for digital inclusion, into many, many organizations who have a lot of skills in these services, and how can we be thinking about what that looks like in our local environment and connecting and plugging into that better. And then lastly, how can we be thinking about health in all policies? Clearly, broadband has come up for us with telehealth and really understanding that broadband is not available to all communities in the same way. And how can we in the healthcare industry advocate for things like broadband that might also impact the types of products and tools that we want to be delivering to improve the health and wellness of our populations? So it was a pleasure being here today. I hope I left you with this idea that technology does have the potential to exacerbate some disparities, but it's not a silver bullet kind of solution to just invest in one of those levels. However, I would say cross-disciplinary and focused efforts really can make a difference. The more we center equity with our measurement, with our approaches, and in our co-design of platforms and solutions, I would say that we can make a lot of impact, and we actually have a lot of tools available to us in our toolbox. And how can we think about starting to implement them and snowballing what we're doing to actually make sure that this is a central part of what we're thinking about with our telehealth modalities to make real impact on equity moving forward. And then lastly, these are some resources. I linked them out here, but many of them are also linked from within the toolkit itself, which if you're playing around with the toolkit, you'll see many of these resources also available there. So I think that's it. I wanted to leave at least 15 minutes conversation, and I'll leave it to Bernadette to decide how to question.
Yeah, absolutely. Thank you so much, Dr. Lyles, for that presentation. We have a couple of questions from the audience here. The first question is from Talia, and it seems that the current theme is to return to all in-person visits, but our underserved patients clearly have benefited from increased access via telehealth. Is there any cost benefit data that would help us argue for the healthcare value of continuing telehealth?
Great question. I think all patients have had some benefits of having telehealth offered to them at scale. And so maybe a silver lining, if there are any silver linings of the pandemic, is that we tried it out and really have some offering of it at scale. In terms of cost data, from the academic side, I would say it's a little tricky because we have to think about the types of utilization use cases, like appropriate utilization use cases versus inappropriate use cases. And so the data has not been, it's just not, I think if we wait for that data, in my personal opinion, we might be waiting for a while. And I think the other way to think about it is really thinking about it from a patient-centered lens. We have to be delivering care that patients want and giving them their access to the types of visits that they want at the time that they need it. And if we think about it from that patient-centered language, knowing that we'll be in a more value-based sort of, payment environment in the future, we really sort of have to be doing, like if you think about it from that, we're going to be doing telehealth and sort of have to be doing telehealth. And so if you flip it from that perspective, then we need to look at the quality and the outcomes and sort of develop some of those workflows and some of the use cases for utilization moving forward. That's my personal opinion, because the cost, if we get too caught up in getting the cost data, I think it'll delay us into really giving patients what they need and want. So that's how I think about it. And I think there's enough evidence that patients want this and that we're moving forward with it. And now we just have to make sure that we're offering it well to everybody and doing a good job with what we're offering.
Awesome. The next question is, what is the most common misstep organizations, let me just read here, organizations make when trying to implement innovative solutions with an equity lens, just from your experience and maybe a recommendation?
Yeah, I think that's why I sort of started with that multifactorial slide, is I think I see a lot of organizations just assuming it's one strategy that will achieve equity. And all the strategies are important. I don't mean to say that if you're not focused on patient digital skills, that it's not important. But if you're only focused on asking patients about one thing like broadband and not working on workflows or your call centers or other things that might help them actually use those technologies that we're offering them, I think so that sort of individual and laser focus can prevent you from thinking about the whole. That being said, I hope I didn't leave you with you have to do everything all at once. I mean, I hope that these strategies are linked across the levels. And so the more you're focused on equity across the levels, I think sometimes it's easy to gain patient input if you're centering communities' voices and sort of what they're looking for and how to improve your programs. It's easier than to screen them with the right questions. And, like all of those, they can sort of blend for each other. So I think that's one of the biggest problems that I've seen organizations sort of take on. Yeah, I want to of course, I keep going forever. I'll wait and come back to some other ones if there's more time in a minute.
Yeah, sort of related to that. What are ways that you would suggest measuring success throughout time?
Yeah. I think on the measurement space, that's sort of why I was talking about looking at your own data and really being explicit about it. I would say the other thing that I've noticed a lot is that it's really great to report out who's the overall rates of video visits or the overall rates of patient portal or app use or whatever we're implementing. I would say we actually need dashboards that have disparities measures on them as well, which some of us have been doing for a long time with quality measures and other things, but I think we need both gaps, like if we're trying to offer, for example, language concordance, like making sure our limited English proficient patients or others are taking up video visits, then we need a measure that shows those, that calls out those kinds of measures or looks at the difference between LEP patients and English-speaking patients in our population. So I would say that on the metric standpoint, we need to be looking at disparities reduction in addition to overall uptake and use, and to embed that across multiple of our products or projects and programs at the healthcare system level. And so, yeah, I think from a success level, even just doing that, is that the same as health improvement or improving chronic disease measures with telehealth? Yes, that's coming and that's down, but at the fundamental level, I think we really need to be focused on use and uptake. A lot of times I've seen dashboards that people are tracking that, but I think we need to dig down and really get into that. If we're gonna start to think about implementing a program to improve that, we need to have a baseline, really good baseline data to know what we're trying to improve.
Great. We have a question here on the interpreter services and incorporating that into the telehealth visit. And just from your experience, have you how successful has that been?
Yeah, I didn't show a lot of that data, but there's definitely some big disparities in who took up overall telehealth by language status, and at least in California. We've seen a lot of the sites that were part of that Center for Care Innovations group, the 40 sites that were part of that collaborative working on telehealth equity, serve a predominantly non-English speaking population. And what I've seen at those sites is the sites that had a higher proportion of bilingual, bicultural staff were best positioned to navigate telehealth for all patients, because they were able to use their existing resources, their existing staff models to sort of navigate around. And they didn't need as much interpreter use on the visits because they had the capacity in-house. The sites that served many, that worked best for sites that were serving predominantly one language in their population, so like Spanish speakers in particular in California, and had a lot of bilingual Spanish speaking staff on hand. The other sites that served many languages, there was a lot of workaround workflows, phone interpreters, video visit, very little three-way interpreters. That type of implementation and workflow, I think it's possible with some platforms, but was not the standard in what we've seen. And so language itself, to me, it is a huge area that we need to be focusing on if we're going to be improving the equity of our telehealth implementation. So I saw some sites doing it, but when we interviewed them, when we looked at their data, but I wouldn't say that the platforms were ready and able to do it in a seamless way, that everyone felt really great, frankly, about what that workflow looks like. So I think we have a lot of work to do on that for me.
Awesome. I think that's all the questions that we have so far. Is there any final comments that you want to make?
I just hope I left you with enough resources to feel empowered, all of you to feel empowered to work on this in your everyday practice. And I would encourage all of you to really check out that toolkit, because if you're really interested in, not from an academic lens, right? I showed you a lot of academic language, but I would say the toolkit resources are really like, what are the top 3 or 4 questions that we can start asking patients that can really understand their needs and preferences? And I think that's the kind of thing that I hope everyone can consider implementing in their own delivery systems, because we need more information from patients. We need to be able to think about this from a patient-centered standpoint. And I think it's like fusing the IT side of our institutions with the equity side of our institutions and integrating them together. I think there's so much we can do. So hopefully I gave you ideas and strategies of what you all can do, soon.
Wonderful. Well, thank you so much for all the work that you're doing in this space. And thanks for taking the time today to share that with all of us here that are live. And Dr. Lisle, is that your handle for Twitter? Are these handles for Twitter if folks want to contact you or reach out? Okay, great. So that's up on there on the screen, and we'll be sharing the slides afterwards along with the links that are included in the presentation. So you all will have access to that. I just have a couple of things here at the tail end of the presentation. We do have another telehealth immersion program session coming up that will be focused on telehealth for primary care. Registration is open for the September 14th event, and we invite you all to join us. You can go to www.ama-assn.org/telehealth-immersion to register for this event, as well as others. We also have an extended mini boot camp coming up on September 25th that will be hosted in collaboration with the ATA Telehealth Awareness Week. During this boot camp, there will be a focus on health at home and an opportunity for deep dive breakout sessions across various medical specialties. And you can find more information about the boot camp and to register also on our website. This is my contact information if you have any questions about the program. And we thank you all so much for joining us. There will be a 4-question survey at the end that we ask for you to just take a minute to complete for us. We really appreciate it. Thank you, Dr. Lyle, for joining us today, and thank you all so much for attending. Have a great night.